Imagine implanting a synthetic device into a patient's body to, cure a debilitating condition, only to realize that the absolute second it is inside, it becomes completely invisible to standard medical imaging.
Right. It just vanishes.
Exactly. You can't capture it on an X-ray. A traditional CT scan just passes right through it. So if something goes wrong, the standard diagnostic tools that doctors rely on, like every single day, they're suddenly completely useless.
Yeah, it creates this really fascinating diagnostic void because standard radiologic imaging, well, it relies almost entirely on tissue density.
Like looking at bones.
Exactly. Bone is highly dense, so it absorbs the radiation and shows up stark white on an X-ray film. But a thin synthetic polymer, specifically the polypropylene mesh that's used in these mid-urethral slings, it just lacks that atomic density.
So the radiation doesn't even see it.
It just simply passes through it, yeah. It leaves the mesh completely camouflaged within the surrounding soft tissue of the pelvic floor.
Which perfectly sets up the central mission for our deep dive today. Welcome, everyone. We are exploring the hidden mechanics of the mid-urethral sling, or MUS. And these are heavily utilized to treat stress urinary incontinence.
Very common procedure, yeah.
Right. Millions of these are implanted, and honestly, they're highly effective. But the diagnostic challenge is immense for you or anyone in the medical field. If a patient develops complications years down the line, how do doctors map a hidden piece of plastic and measure its exact tension down to the millimeter?
Well, to solve that, you have to completely abandon the concept of looking for density with radiation. You have to pivot to using sound.
Sound, like ultrasound.
Exactly. The first line detective in this space is ultrasound specifically, transperineal ultrasound, or pelvic floor ultrasound.
Okay, so if radiation passes right through the synthetic polymer, sound waves must interact with it completely differently. Like it must be some acoustic property that gives the mesh away, right?
Yeah, you hit the nail on the head. It all comes down to a physical property called echogenicity.
Echogenicity.
Right. So ultrasound works by transmitting these high-frequency sound pulses into the body and recording the echoes that bounce back off internal structures.
Okay, that makes sense.
And human soft tissues absorb, transmit, and reflect sound in a very predictable gradient manner. But synthetic materials like polypropylene, they have a drastically different acoustic impedance than human tissue.
So it's basically hitting a brick wall.
Yes. When those sound waves hit the mesh, they don't pass through smoothly at all. They hit that acoustic wall and bounce back incredibly strongly.
It makes me think of like shining a flashlight into a dense, soupy fog. If you just have fog, the light diffuses and you just see this hazy gray, right?
Yeah, exactly.
But if that beam suddenly hits a piece of highly reflective tape on a jacket, it just flares up bright white. It stands out in complete contrast to the natural environment.
That is precisely how it appears on the screen. The ultrasound probe emits the sound, and the mesh reflects it back so intensely that the sling appears as this striking hyperechoic line.
Meaning it's really bright.
Brilliantly bright on the monitor. And because these slings aren't just solid strips of plastic, but they're rather, woven mesh, the sound waves actually interact with the tiny gaps in the weave.
Oh, wow. So you can see the texture.
You really can. When you look at it in a cross-section, it creates a distinct cross-hatched or dot-dash appearance.
So you aren't just seeing a solid line, you are seeing the actual textured pattern of the weave hiding inside the tissue. And I imagine because it's bouncing so much sound back to the probe, there must be like a void left behind it.
Yes, exactly. It creates this phenomenon known as posterior acoustic shadowing.
Posterior acoustic shadowing.
Because the mesh reflects nearly all the sound energy back up to the probe, very little sound actually penetrates deeper into the tissue behind it.
So it's casting a literal shadow.
A literal acoustic shadow on the image below the sling, yeah. For a radiologist, seeing that bright dot-dash pattern, followed by a deep shadow, that's the definitive acoustic signature of a synthetic implant.
That's wild. But capturing that signature requires a very specific acoustic environment, right? Our sources mentioned you can't just place the probe anywhere. For one, the patient's bladder needs to be filled to exactly 300 milliliters prior to the scan.
It does. It has to be very precise.
I imagine that's because fluid transmits sound waves much more efficiently than, say, empty space or bowel gas.
It does, yeah. A filled bladder serves as the perfect acoustic window. The fluid acts almost like a magnifying medium for the sound waves, giving you this crystal clear view of the crucial structures behind it.
Namely the bladder trigone and the bladder neck, right?
Exactly. Furthermore, That specific 300 milliliter volume mechanically pushes the surrounding pelvic organs into a standardized, predictable anatomical position.
So everyone is being measured on an even playing field. And crucially, the high-frequency probe, which is often 3D, is placed externally at the perineum or the introitus rather than transvaginally.
Right, which is a key distinction.
It makes perfect sense biomechanically. I mean, if you were to insert a transvaginal probe, you would physically compress the urethra and the surrounding tissues, right?
You'd completely distort the anatomy.
You'd artificially alter the very tension and shape you're trying to measure.
Exactly. External placement ensures the structures remain in their natural resting state, which is vital because, merely finding the mesh is only step one. The far greater challenge is evaluating how it functions.
Because the sling is a functional device. Its entire purpose is dynamic compression.
Right.
For someone dealing with stress urinary incontinence, their urethra basically lacks the structural support to stay closed during moments of increased intra-abdominal pressure, like when they laugh, jump, or cough. So the sling acts as a backstop.
Right. When that pressure spikes, the urethra is forcefully pushed down against the synthetic mesh, pinching it shut and, ideally, preventing urine leakage.
So if that's the mechanical goal, just taking a static image while the patient lies still on the table, that tells you almost nothing about whether the device is actually working. You have to watch it react under physical stress.
Precisely. And this is where ultrasound proves its unparalleled value. It provides real-time, high-resolution temporal imaging. The physician assesses the sling at rest and then asks the patient to perform a Valsalva maneuver.
Basically bearing down or coughing.
Yeah.
Wait, so you're telling me the ultrasound isn't just taking a picture, it's acting like a live-action video camera watching this tiny piece of mesh physically bend and grip the urethra in real time.
That is exactly what it's doing. They're looking for two primary metrics during that dynamic stress: tension and shape.
Okay, let's talk about tension first.
So, to quantify the tension, doctors look at the sling pubis gap, or the SPG. This is the exact distance between the sling and the pubic symphysis during maximum Valsalva.
Giving them a hard number.
Right, a numerical indicator of how tight the sling becomes under load.
But the shape of the mesh itself tells an even more immediate story, doesn't it? I mean, if it's placed correctly, it shouldn't be strangling the urethra when the patient is just resting.
No, definitely not. It should lay relatively flat and parallel to the posterior wall of the urethra at rest.
Just acting as a passive hammock.
Exactly, just a hammock.
Okay.
But the moment the patient coughs or strains, you want to see that flat line actively flex and curl into a gentle U shape, embracing and compressing the urethra.
Okay, but our sources point out a massive diagnostic red flag here. If the doctor places the probe and sees that the sling is already heavily curled into a C shape while the patient is completely at rest, the biomechanics are failing.
That is the danger zone.
The sling is drawn way too tight, constantly kinking the urethra.
Yeah, if the sling is C-shaped even at rest, the patient is essentially living with a permanent artificial obstruction. And this leads to profound voiding dysfunction.
Because the bladder is fighting against a closed door.
Right. The detrusor muscle, the main smooth muscle of the bladder wall, has to generate dangerously high pressure just to push urine past that kink. Over time, that high detrusor pressure can lead to severe bladder wall thickening, chronic urinary retention, and significant pelvic pain.
And the ultrasound allows doctors to see this constant mechanical strangulation instantly.
It does. It also lets them assess concordance.
Concordance.
Yeah, basically making sure the urethra actually moves in sync with the sling during a cough. If the urethra shifts downward under pressure, but the sling stays rigidly locked in a different position, they're out of sync.
The urethra basically misses the backstop.
Exactly, and the dynamic compression fails. But, none of this dynamic movement matters if the sling was anchored in the wrong geographical location to begin with. The sheer precision required here is staggering.
It really is like a microscopic game of real estate. The sources say that to be effective, the mid-urethral sling must be placed exactly 50% to 75% along the length of the urethra, measuring down from the bladder neck.
Right, because that specific segment is the urethra's high-pressure zone.
The exact point that takes the brunt of the physiological force when the patient strains.
That is the anatomical sweet spot, yeah.
Yeah.
It's where the sling can provide optimal resistance without compressing the more delicate structures near the bladder neck.
But finding the right spot along the length of the tube is only half the battle, right?
Right.
The depth of the sling, how intimately it sits against the urethral wall, is measured down to the millimeter using what's called the SLSM distance.
The distance from the sling to the longitudinal smooth muscle of the urethra.
Okay, let's unpack this. 3 to 5 millimeters is roughly the thickness of 2 pennies. It's like tuning a piano string. If you are off by a fraction of a millimeter, the whole instrument is out of tune.
It's a great analogy because the tolerances are just that tight. If that mesh rests less than 3 millimeters from the longitudinal smooth muscle, it's sitting way too close.
And the urethral wall isn't just a static pipe, right?
Yeah.
It's highly vascular, full of nerves.
Exactly, it's a mucosal and muscular layer. So if a rigid synthetic mesh is constantly grinding against it at a distance of less than 3 millimeters, you invite a host of severe complications.
Like what?
Well, the localized inflammatory response alone can cause chronic pelvic pain, overactive bladder symptoms from the constant nerve irritation, and profound voiding difficulty.
And conversely, if a surgeon is just slightly too conservative and anchors the mesh, say, 4.6 or 5.5 millimeters away, the tension is lost entirely.
Right, the backstop is positioned too far back.
So the patient goes through an invasive surgery, endures the recovery, and still suffers from stress urinary incontinence because the meshes can't physically reach the urethra to compress it.
It results in total treatment failure, which is why having transperineal ultrasound mapping postoperatively completely changes the landscape of pelvic floor medicine.
It's definitive proof.
Yeah. Before this, diagnosing failures relied heavily on subjective patient symptoms and blind deduction. Now, a physician can look at the screen, measure an SLSM distance of 2.1 millimeters, and say definitively, your sling is too tight and too close.
Okay, so pelvic floor ultrasound is clearly the undisputed gold standard for the immediate suburethral space. It gives you real-time dynamic movement, it highlights the synthetic polymer, and it measures tension down to the millimeter.
It does.
Which honestly makes me wonder why MRI is even utilized in this specific diagnostic pathway. If MRI can see the whole global anatomy and the infections, why not just use MRI for everything from the start?
Well, it comes down to the physical limitations of sound waves. Ultrasound has a very small acoustic window. High-frequency sound provides phenomenal resolution for superficial structures, but the deeper the sound waves travel into the pelvis, the more they degrade and scatter.
So it's a field of view problem. You have a brilliant high-definition view of the engine, but you can't see the rest of the car.
Precisely. We have to remember that a mid-urethral sling is essentially a long synthetic ribbon. While ultrasound brilliantly captures the center of the ribbon where it cradles the urethra, it completely loses sight of the arms of the ribbon.
Because they trail off deep into the pelvic anatomy.
Right, to anchor into distant muscle and fascia. So when a physician needs to see the edges of the map, they must rely on MRI.
Because MRI provides a global panoramic view of the entire pelvic basin. And our sources highlight how this becomes critical when you need to identify the exact surgical approach used years prior.
Yeah, because the anchoring arms take wildly different anatomical paths depending on the type of sling.
Right, like the retropubic slings versus the TOT sling.
Exactly. So the retropubic sling forms a narrow, vertical U shape. The surgeon passes the arms of the mesh anteriorly, driving them up right behind the pubic bone to anchor into the rectus fascia in the lower abdomen.
And MRI excels at tracing those arms all the way up.
It does, whereas the transobturator tape, or TOT sling, takes a completely lateral route.
Forming a much wider hammock shape.
Right, with the arms passing out sideways through the obturator foramina, the large openings in the pelvic bone. MRI can capture that wide lateral sweep deep into the obturator muscles in a single global image.
That makes sense.
Furthermore, MRI is specifically highlighted as being superior for detecting intrapelvic infectious complications, like an abscess forming along the distant track of the mesh arm, which an ultrasound probe at the perineum could simply never reach.
But the trade-off is that MRI lacks the temporal resolution of ultrasound. You can't easily have a patient perform repeated aggressive Valsalva maneuvers inside an MRI scanner and capture the real-time millimeter-by-millimeter flexion of the mesh.
Right. It takes a static photograph, not a live-action video, and it's wildly expensive. So the ultimate diagnostic roadmap really requires both: ultrasound for the dynamic close-up and MRI for the anatomical wide angle.
And constructing that roadmap is absolutely critical when you look at the complication rates from the patient advocacy data.
The data is deeply sobering.
It really is. When patients undergo revision surgeries for these slings, a staggering 42.3% report persistent chronic pain. We are talking about a massive cohort of people who sought to improve their quality of life, only to end up with debilitating nerve entrapment or catastrophic mesh erosion.
Where the abrasive polymer actually grinds its way through the urethral or vaginal wall.
Yeah.
It is a devastating clinical scenario.
It's horrific. And when a surgeon goes back in to attempt a revision or a total removal, operating without advanced imaging is basically flying blind in a highly vascular, scarred environment.
Exactly. The combined MRI and ultrasound data provides a definitive surgical roadmap. Before making a single incision, the surgeon knows exactly how many slings are embedded because, some patients have multiple from prior failed attempts.
Right.
They know the exact depth of the erosion, and they can see if the mesh is pulling asymmetrically.
But even with both modalities, radiologists face a massive diagnostic trap. The sources call it the scar tissue trap.
Oh, this is the single greatest challenge in pelvic floor imaging.
Because human fibrotic scar tissue is essentially just dense collagen. And structurally, dense collagen has a very similar acoustic impedance to synthetic plastic, right?
They both act as acoustic walls that bounce sound waves back to the probe. A thick band of surgical scar tissue from a previous procedure can create a hyperachoic line on an ultrasound and a dark fibrotic band on an MRI.
Perfectly mimicking the signature of a synthetic sling.
Exactly.
Mm.
If a surgeon operates under the assumption they are removing a piece of errant mesh, but they are actually excising structural human scar tissue, they can cause irreversible damage to the pelvic floor.
So how do you break the tie? I mean, if they look structurally identical, you must have to look at physiological function, right? Human tissue has a blood supply, but a synthetic polymer doesn't.
That is the exact physiological loophole they exploit. On ultrasound, doctors sometimes have to rely on a feature called color Doppler flow.
Which detects blood flow.
Right, the movement of red blood cells. Even dense human scar tissue usually maintains some degree of microvascularization.
So they isolate the dense, bright mass on the screen and activate the Doppler. If it lights up with blood flow, it's human tissue.
And if it remains a complete vascular void, it is definitive evidence of synthetic mesh. It relies on physiology to confirm what structure alone cannot.
So what does this all mean for the patient? It means that when someone is suffering from mystery pain years after a procedure, this imaging acts as the definitive proof, turning a vague symptom into a visible, fixable target on a screen.
It restores the precision we expect from modern medicine. Assessing a mid-urethral sling is a highly dynamic diagnostic art form. It requires leveraging ultrasound to watch the invisible move in real time, measuring tension down to a fraction of a millimeter and bridging the gaps with MRI.
All to resolve truly life-altering complications. The sheer depth of the detective work happening just millimeters beneath the surface is astounding.
It really is.
Yeah.
Yet, the technology is on the cusp of another massive leap. We just discussed how both ultrasound and MRI currently struggle to tell the difference between synthetic mesh and natural human scar tissue because they look identical structurally.
Right.
This raises an important question for the future of medicine. As we move toward artificial intelligence in radiology, how long will it be before imaging technology evolves beyond just seeing shapes and can actually analyze the molecular density or chemical signature of tissues in real time, instantly separating the human from the synthetic without making a single incision?
Wow. An imaging platform that identifies objects by their molecular makeup rather than just their acoustic shadow. That is something to think about. It promises to rewrite everything we know about medical diagnostics. Thank you for joining us on this deep dive. Keep asking questions, and we'll see you next time.